to USMLE Review Podcast, which is also the deep dive. This is where we take, a stack of information, could be articles, research, maybe your own notes, and we really help you unpack the most important insights.
Yeah, think of it as your shortcut to getting well-informed without drowning in all the details.
Exactly. And in this deep dive, we're tackling a collection of medical case studies. These are specifically sourced from a review meant to sharpen diagnostic skills, like for medical exams.
That's right. These cases, they're designed to test a pretty deep understanding of clinical principles. They give you specific details, and you have to connect the dots.
So our mission today is basically to guide you through these scenarios.
Yeah.
Highlight the critical findings, maybe reveal some of the diagnostic thinking process that's laid out in the source material.
And really pull out the core knowledge that makes it all click. You've brought these challenging cases, and we're here to explore them together with you.
Okay, sounds good. Let's unpack this material and see what these cases can teach us about, diagnostic reasoning.
So we're looking at clinical vignettes, essentially. Little mini mysteries, right? And the key is always picking out the most relevant bits of information.
Mm-hmm.
We'll go through the specific details presented in each case, and then we'll walk through the rationale, the why, provided in the source, to understand how you get to the right diagnosis.
And crucially, why it's the right one. It's about seeing how those, seemingly small details build up a picture.
Exactly. It's pattern recognition.
Okay, let's jump into the first one. Case 1, this corresponds to question 31 in the sources. We've got a 3-year-old boy.
Okay, very young.
Yeah. And his main issue. His left eye is bulging outwards. That's exophthalmos. He's also got pain in that eye.
Pain and bulging. All right.
An MRI confirms there's a mass there.
Uh-huh.
And specifically, it involves the ocular muscles, the muscles around the eye.
Okay, location is key. Ocular muscles.
And then the biopsy report gives us this critical microscopic finding. Malignant cells, and importantly, some of these cells show striations.
Striations. Okay, so when you hear exophthalmos,
Yeah,
your mind might jump to Graves' disease.
right. That's common.
But, like the source points out, that's really, really unusual in a 3-year-old.
Yeah.
Highly unlikely. Plus, there's no mention of thyroid stuff. No neck mass.
So that's probably not it.
Probably not. The real clues here, the sort of flashing lights, are the location in the ocular muscles and that detail about striations in the malignant cells.
Okay, so why are the striations such a big deal? What does that tell us?
Well, striations are basically the visual hallmark of muscle tissue. Think skeletal muscle, like your biceps, or cardiac muscle.
Okay.
So since this mass is in the extraocular muscles, which are a type of skeletal muscle, finding striations in the malignant cells tells you this cancer started from muscle cells. It's muscle-derived.
And that points directly to
That points you strongly towards rhabdomyosarcoma, a malignant tumor of muscle.
rhabdomyosarcoma. Okay. And the source walks through why other things you might think of don't quite fit, right? Once you have all the details.
Exactly.
Yeah.
Like neuroblastoma that's usually found in the abdomen.
Right.
Often calcified, can cross the midline, or sometimes in the chest, the posterior mediastinum. None of that fits an eye muscle mass.
Doesn't fit at all. What else?
Or pheochromocytoma.
Right.
That causes symptoms like wild swings in blood pressure, headaches, episodic stuff. Doesn't fit a localized eye mass in a kid.
Right.
Retinoblastoma is a common eye tumor in kids, sure. But it's a tumor of the retina itself, the back of the eye, not the muscle around it. It gives you that white reflex, the leukochorea, and it's linked to the RB gene mutation. No muscle involved, no striations.
Okay. And thyroid cancer.
Again, wrong location. That would involve the neck.
So it's really the combination. The patient's young age, the precise location in the muscle, the fact that it's malignant, and especially that microscopic detail, the striations, that's the pathway.
That's the map. The source really nails it. Rhabdomyosarcoma, malignant muscle tumor. Often found in the GU system or head and neck, but yeah, about 10% can show up in the eye orbit. It's also one of those classic small blue cell tumors you learn about.
It's amazing how those really specific, almost small-sounding details, age, location, microscopy, can just narrow down the possibilities so quickly, even when it sounds complex initially.
Absolutely. It shows how crucial that pattern recognition is based on the key findings presented. You have to know what to look for.
Okay. So, from a rare childhood cancer, let's switch gears completely. Case 2, question 32. This one features an 18-year-old woman who has sickle cell disease.
Okay, sickle cell. Important history.
Yeah, she comes in with severe pain in her right upper abdomen, the RUQ, and it radiates up to her shoulder. Plus nausea. An ultrasound confirms gallstones.
All right. So the immediate question the source brings up is, okay, she's got sickle cell disease, she's young. Why is she getting gallstones? You might think diet or something first.
But the sickle cell is the big clue.
It's the massive clue here. The source explains the mechanism really well. Sickle cell disease causes chronic hemolysis.
Meaning constant breakdown of red blood cells.
Exactly. Red blood cells are breaking down way more than usual all the time. And when red blood cells break down, they release a lot of bilirubin, specifically the unconjugated kind.
Okay, so lots of bilirubin floating around.
And this excess bilirubin gets processed by the liver and ends up concentrated in the bile. Over time, if there's too much bilirubin in the bile, it can crystallize out and form gallstones.
Ah, so they're bilirubin gallstones.
Precisely. Which are different from the more common cholesterol gallstones that people usually think of.
And the source contrasts that, right? Cholesterol stones are usually linked to other things.
Yeah, typically linked to factors like being overweight, being female, maybe having had multiple pregnancies, or even rapid weight loss.
Yeah.
Things that increase cholesterol concentration in the bile.
But this patient's history, the sickle cell, points straight towards the bilirubin pathway.
It does. It directs your thinking immediately. The source also kind of dismisses the other multiple choice options, pretty quickly calls them bogus answers about like decreased liver secretion or problems with bile salt reabsorption.
And definitely rules out parasites causing these stones.
Yeah, that was a bit out there. But this case is a really neat illustration of how a chronic condition affecting one system, the blood cells, can cause a complication in a totally different organ, the gallbladder.
Through a very specific mechanism.
Right, that clear physiological link. Chronic hemolysis leads to excess bilirubin, which leads to bilirubin gallstones. Connects the dots perfectly.
Okay, let's do a complete flip now. A biostats question. Case 3, question 33. We have a sample, 100 people. Mean white blood cell count is 7,500. Standard deviation is 1,000. And we're told it's a normal, Gaussian distribution.
The classic bell curve.
Exactly. And the question asks, what count range includes 50% of individuals below the mean?
Ah, yes. The biostats question that sounds more complicated than it is. The source highlights this beautifully.
It does. It says you don't actually need the standard deviation number here, right? You don't need that 68, 95, 99.7 rule for this particular question.
Nope. All you need is the fundamental property, the definition of a normal distribution. Well, in a perfect normal distribution, the average is smack dab in the middle. It's also the same value as the median, the middle value, and the mode, the most frequent value. They all line up.
Okay, mean is in the middle.
So, by definition, if the mean is the exact center point, then exactly 50%, half of all the data points, must fall below that mean value.
And the other 50% must fall above it.
Precisely.
Yeah.
So if the mean white count is 7,500 and it's a normal distribution,
then 50% of the people just have a count less than 7,500. The range is everything below 7,500.
That's it. The source points out this no math needed aspect. It's testing your understanding of what the mean actually means in the context of a normal distribution. Half the population is below it. Simple as that.
That's a great point for test taking too, isn't it? Don't jump to complicated formulas if the basic definition gives you the answer right away.
Absolutely. Know your definitions.
Okay, back to the clinics. Case 4, question 34. This is a 52-year-old woman. She comes in with some fairly non-specific symptoms initially: fatigue, constipation, frequent urination. Okay, kind of vague stuff.
But then the physical exam finds diffuse crackles in her lungs.
Yeah.
That crackling sound suggesting fluid or inflammation maybe. And her chest x-ray is significant.
What does it show?
Bilateral hilar lymphadenopathy. So swollen lymph nodes near the center of the chest where the main airways go into the lungs. And also interstitial infiltrates, which suggests inflammation or maybe fluid within the lung tissue itself.
Okay, so definite lung findings. And the labs.
Labs show high serum calcium 11.1, which is elevated. But importantly, her parathyroid hormone level, PTH, is decreased. Low.
Okay, hold on. High calcium, but low PTH. That seems counterintuitive, doesn't it? Usually PTH drives calcium up.
It does seem backward, and that specific pattern lung issues, high calcium, low PTH, is the huge clue here. It points very strongly in one particular direction.
Which is?
Sarcoidosis. As the source explains, this combination is highly suggestive of sarcoidosis. It's a systemic inflammatory disease where you get these granulomas.
Specific inflammatory cells.
Yeah, exactly. They form in various organs, very commonly the lungs and lymph nodes, which fits the X-ray findings. And inside these granulomas are specific cells called epithelioid macrophages.
And these macrophages, they're the key to the calcium puzzle. How does that work?
That's the really fascinating mechanism the source lays out. These macrophages within the sarcoid granulomas actually start producing an enzyme called 1-alpha hydroxylase.
Isn't that normally made in the kidneys? For vitamin D?
Exactly. Normally, the kidney uses 1-alpha hydroxylase to convert the inactive form of vitamin D, calcidiol, into the active form, calcitriol. But in sarcoidosis, these macrophages are doing it too, outside of normal regulation.
So you get extra active vitamin D being made by these granulomas.
Precisely. The macrophages are essentially acting like little rogue vitamin D factories. This extra active vitamin D, calcitriol, then increases calcium absorption from your diet in the gut,
Driving the blood calcium level up.
Right. And then when your blood calcium gets too high, the body's normal response is to shut down PTH production from the parathyroid glands. That's the feedback loop.
Wow.
So you end up with high calcium caused by macrophage-driven vitamin D activation, which then suppresses the PTH. The source mentions this is sometimes even called hypervitaminosis D because it mimics taking way too much vitamin D.
That's an incredibly elegant, if complicated, pathway linking the lung inflammation to the calcium level, and the source rules out other causes of high calcium.
Yeah, because they don't fit this specific pattern.
Right.
Like bone metastases causing high calcium, no suggestion of cancer meds here. Or PTH-related peptide, PTHRP. Some cancers, like squamous cell lung cancer, make that. But you wouldn't expect these lung findings in the low PTH.
And primary hyperparathyroidism is out because PTH would be high, not low.
Right. And hypothyroidism can sometimes cause mild hypercalcemia by affecting bone turnover, but it doesn't explain the lung picture or the suppressed PTH seen here.
So this case is just a perfect example of how really specific lab values, that low PTH despite high calcium, combined with the clinical picture, the lung findings, can pinpoint a diagnosis and reveal this complex underlying biology.
It really is a great teaching case.
Okay, let's look at something maybe more common, but where the history is again a major clue. Case 5, question 35. We have a 55-year-old woman, and she has type 2 diabetes.
Okay, another key comorbidity.
She's had a 2-month history of severe vaginal pain and itching, also pain during intercourse dyspareunia, and a white vaginal discharge. On exam, the vaginal lining, the mucosa, is red and swollen, and a smear shows pseudohyphae.
Okay, the absolutely critical piece of information here, as the source really emphasizes, is her history of type 2 diabetes.
Why is that so important here?
Because diabetes significantly increases a woman's risk of getting vaginal candidiasis, a yeast infection.
Right. The source used that memorable analogy, calling the diabetic state a sugary body that Candida yeast finds very attractive.
It's a simple way to think about it, but effective. Higher glucose levels in the tissues and secretions can create a much more favorable environment for yeast to overgrow.
Makes sense.
The source also mentions another common risk factor, though it wasn't explicitly in this case vignette, which is recent antibiotic use. Antibiotics can wipe out the normal protective bacteria in the vagina, letting the yeast take over.
Okay. And the physical findings described here, the thick white discharge, often called cottage cheese-like, the redness, the swelling, and then crucially, seeing pseudohypha on the microscopy. Those are pretty classic for Candida, aren't they?
Absolutely classic. Pseudohyphae are those sort of elongated filament-like structures that the yeast forms when it's invading tissue. Seeing those is very characteristic.
And the source quickly rules out other possibilities based on this picture, like chlamydia.
Yeah, chlamydia wouldn't typically cause symptoms for 2 months like this. It's usually more acute, and it's an intracellular bacterium. You wouldn't see yeast forms. Herpes simplex virus, HSV, causes painful blisters or ulcers.
HPV causes warts.
Right. And trichomoniasis usually gives you a frothy, often greenish discharge. The vaginal pH is typically higher, above 4.5. And you see these little swimming single-celled organisms, trophozoites, on the wet mount. Totally different picture from the pseudohyphae of Candida.
So again, a key piece of history. The diabetes plus the characteristic symptoms in exam, and then the definitive microscopic finding. It all points very clearly to a common diagnosis.
It really shows the power of putting together the history, the physical, and some basic lab work or microscopy.
Okay, let's pivot to a neurological challenge. Case 6, question 36. This involves a 24-year-old woman, and it's 1 month after she was in a motor vehicle collision, an MVA.
Okay, trauma history.
She's presenting now with weakness, so she can't walk. Examination reveals weakness and noticeable muscle wasting atrophy, specifically in the small muscles of both her hands.
Okay, weakness and atrophy in the hands. Bilateral.
But then in her legs, her lower extremity, she has increased muscle tone spasticity and very brisk deep tendon reflexes, DTRs, the knee jerk, ankle jerk type reflexes.
So increased tone and hyperreflexia in the legs.
Yes. And she also has a positive Babinski sign on both sides, where the big toe goes up when you stroke the sole of the foot.
Yeah, Babinski present.
And finally, her sensation is absent from the level of her clavicles downwards.
Wow. Okay. So let's piece that together. Weakness and wasting, which sound like lower motor neuron signs in the hands.
Right.
But increased tone, hyperreflexia, and Babinski signs, which are classic upper motor neuron signs, in the legs.
Exactly. And all this after a potential neck injury event, the MBA. That pattern sounds incredibly specific, doesn't it? Pointing toward the spinal cord.
It absolutely does. As the source puts it, this exact combination is basically the slam dunk pattern for a spinal cord problem. Specifically, cervical myelopathy damage or compression affecting the spinal cord up in the neck region.
Okay, but why does that specific mix of signs, LMN in one place, UMN in another, point so clearly to the cervical cord?
It's all about the anatomy. The source explains that lower motor neuron signs the weakness and especially the atrophy or muscle wasting happen at the level of the spinal cord damage. That's where the actual nerve roots exiting the cord or the motor neurons within the cord, the interior horn cells that directly supply those muscles, are getting damaged.
Okay, so damage at the level causes LMN signs there.
Right, but the upper motor neuron signs, the increased tone, the hyperreflexia, the Babinski, those occur below the level of the spinal cord lesion. That's because the injury has damaged the descending motor tracts coming down from the brain. These tracts normally have an inhibitory effect on reflexes, so when they're damaged, you get exaggerated reflexes and increased tone below the injury.
I see. So, in this woman, the LMN signs, the weakness and atrophy in her hands tell you the damage is at the spinal cord segments that supply the hand muscles.
Exactly. That localizes the lesion level generally to the C8-T1 segments of the cervical spinal cord, which provide innervation to the intrinsic hand muscles, often via the ulnar nerve.
And the UMN signs in her legs confirm the damage is above the segments controlling the legs.
Correct. The spasticity, hyperreflexia, and Babinski signs in the legs indicate damage to those descending motor pathways somewhere higher up in the cord, which fits perfectly with a lesion at C8-T1 or slightly above. And the sensory level at the clavicles also helps confirm a lesion high up in the cervical spine.
And the source helps rule out other levels, like if the damage was higher or lower?
Yeah, it mentions that if the lesion were higher, say C5, you might expect breathing problems due to phrenic nerve involvement. If it were C7, the triceps reflex would likely be affected. Lesions lower down in the thoracic spine, like T3 or T5, T5 is roughly nipple line sensation, would cause issues lower down, definitely not intrinsic hand muscle atrophy.
What about the brainstem?
Brainstem lesions could cause UMN signs, but you typically expect to see associated cranial nerve problems like double vision, facial weakness, swallowing issues, which aren't mentioned here, and the pattern of weakness and sensory loss might be different. This specific LMN at level plus UMN below pattern is really characteristic of a spinal cord lesion.
So understanding that fundamental difference between lower motor neuron and upper motor neuron signs and where the tracks run is just absolutely key for figuring out where the neurological problem is located.
It's foundational for clinical neurology, absolutely.
Okay, let's shift again. Case 7, question 37. This is a genetic puzzle presenting as heart disease. We have a 45-year-old man. He comes in with sudden, crushing chest pain, diagnosed as a heart attack, and MI.
45 is quite young for an MI.
Very young. And what really stands out is his family history. It's strong for premature MI, meaning heart attacks before age 50. His father and aunt and uncle all had early MIs.
Wow, okay. Big genetic red flag right there.
And then on physical exam, he has tendinous xanthomas on his hands. These are like fatty deposits you can see or feel under the skin, often near tendons or joints. And his Achilles tendons feel thickened.
Visible signs of lipid buildup.
Okay, and his lab results are pretty dramatic. Total cholesterol is way up at 410, and his HDL, the good cholesterol, is very low, down at 30.
Okay. Putting all that together, the premature MI, the striking family history, those physical signs, the xanthomas, the thick Achilles, and that sky-high cholesterol with low HDL.
It points pretty strongly in one direction, doesn't it?
It screams familial hypercholesterolemia, FH.
And the source identifies the most likely underlying genetic issue as a deficiency in the LDL receptor.
That's the classic defect, yeah. And the most common form of FH, the LDL receptor's job is basically to pull LDL cholesterol, the bad cholesterol, out of your bloodstream and into your cells, especially liver cells.
So if the receptor isn't working properly,
if it's deficient or mutated, it just can't clear LDL effectively. So LDL builds up to really, really high levels in the blood. This leads to accelerated atherosclerosis plaque buildup in the arteries, and that's why you see heart attacks and other vascular problems happening at such a young age.
The source also threw in a nice little explanation about how statins work, which is relevant here.
Yeah, that was a good tie-in. Statins work by inhibiting an enzyme called HMG-CoA reductase inside liver cells. This enzyme is key for the liver making its own cholesterol.
So less cholesterol made inside the liver cell.
Right, and when the liver cell senses it has less cholesterol inside, its response is to put more LDL receptors onto its surface, trying to grab more cholesterol from the blood.
Ah, so the statin indirectly causes the liver to increase the number of LDL receptors.
Exactly. More receptors on the liver surface means more LDL gets pulled out of the bloodstream, which helps lower the overall circulating LDL level. It addresses the clearance problem somewhat.
So the genetic problem is poor clearance of LDL, and statins help boost that clearance. And the source rules out other metabolic issues.
Right, because they wouldn't fit this specific picture. For instance, something like ApoB48 deficiency messes up making chylomicrons, particles that carry fat from the gut, and actually leads to low lipids, not high.
Okay.
HMG-CoA reductase deficiency would mean you can't make cholesterol well, so your LDL would likely be lower, not higher. And lipoprotein lipase deficiency mainly affects triglyceride breakdown, giving you super high triglycerides, which isn't the main picture here with the extremely high cholesterol.
So this case is just a powerful example of how genetics can really set someone up for common diseases, sometimes very early in life. And those physical signs, the xanthomas, are like visible proof on the body of the underlying metabolic chaos.
Exactly. Direct evidence of the cholesterol overload.
Okay. One more case, number 8, question 38. This one also has a clue in the person's build. It's a 19-year-old man, previously healthy, but noted to be very tall, 6'5".
Very tall. Okay, significant finding.
He's playing softball and suddenly gets this severe, sharp upper back pain, and then he collapses.
Sudden collapse, severe pain, bad signs.
Yeah. He's found to be in shock, low blood pressure, fast heart rate, weak carotid pulses. And on his heart exam, they hear something specific. A loud, grade 4 out of 6, late diastolic murmur, heard best along the left sternal border.
Okay, let's connect those dots. The extreme tall stature, the acute severe chest or back pain, the signs of shock, and that specific diastolic murmur at the left sternal border.
The palmist jumps out again, doesn't it? Makes you think of
Marfan syndrome. As the source emphasizes, that tall stature may be combined with other features people might notice, like long limbs or flexible joints, strongly suggests Marfan syndrome. It's a genetic disorder affecting connective tissue.
And how does that relate to the collapse and murmur?
Marfan syndrome weakens connective tissue throughout the body, critically including the walls of major blood vessels, especially the aorta, the big artery coming out of the heart. This weakness puts people with Marfans at high risk for aortic aneurysms, bulges in the aorta, and aortic dissection.
Dissection being a tear in the aortic wall.
Exactly. A tear within the layers of the wall.
Yeah.
And that sudden severe, often described as tearing or ripping chest or back pain, is the absolute classic symptom of an acute aortic dissection. It's a true medical emergency.
And the murmur, how does the dissection cause that?
Well, the dissection, the tear, can propagate along the aorta. If it extends down towards the heart and involves the root of the aorta where the aortic valve sits, it can damage the valve support structures.
Causing the valve to leak.
Precisely. It can cause aortic regurgitation. The aortic valve doesn't close properly, so blood leaks backwards from the aorta into the left ventricle during diastole, the heart's filling phase.
And that backward leak creates the sound.
Yes, that backward flow of blood creates the diastolic murmur. And aortic regurgitation murmurs are often heard best along the left sternal border, exactly as described in this case.
So the tall build suggests the underlying genetic risk, Marfan's, which leads to the weakened aorta, which then dissects, causing the pain and shock, and the dissection damages the valve, causing the specific diastolic murmur.
Wow.
It's a direct chain of events, and the source helps distinguish this murmur from others based on timing and location.
Right, like atrial septal defect.
That causes a systolic murmur, usually with a fixed split-second arc sound. Different timing, different mechanism. Mitral stenosis is diastolic, yes, but typically heard best at the apex, the bottom tip of the heart, often with an opening snap sound.
Papillary muscle rupture.
That usually happens after a heart attack, causing severe mitral regurgitation. A holosystolic, throughout systole murmur at the apex. Again, wrong timing, wrong location, different clinical context. And a perforated tricuspid valve would cause tricuspid regurgitation, a systolic murmur at the lower left sternal border. So the diastolic timing and the left sternal border location, plus the whole clinical picture of sudden collapse in a very tall young man, really points strongly to aortic regurgitation, secondary to an aortic catastrophe like dissection.
It fits perfectly. This case really drives home how a person's physical characteristics, like being exceptionally tall, can be a vital clue to underlying genetic risks with potentially devastating consequences. And it highlights why sudden, severe pain, especially with shock or new heart sounds, needs immediate, urgent evaluation.
Okay, let's go microscopic for our last case. Case 9, question 40. This describes a woman who's recovering from ARDS, acute respiratory distress syndrome, a severe form of lung injury. In her case, it was triggered by pancreatitis.
Okay, so severe lung damage, now hopefully recovering.
Yes. And the question apparently presented a drawing of the alveolar wall, the structure of the piney air sacs in the lungs, and asked which labeled cell type is responsible for regenerating the injured lung lining, the epithelium.
So we need to know our alveolar cell types and their functions.
Seems so.
Yeah.
What are the key players down there?
Well, the source explains the main ones. You have type I pneumocytes. These are extremely thin, flat cells that cover like 95% of the alveolar surface area. Their main job is gas exchange. They're super thin and sit right next to the capillaries, making it easy for oxygen and CO2 to pass across.
Okay, type I for gas exchange. What else?
Then you have type 2 pneumocytes. These are different. They're more cube-shaped, larger, and have granules inside. They have two really important jobs.
Which are?
First, they produce surfactant. That's the substance that lowers surface tension inside the alveoli, preventing them from collapsing when you breathe out. Very important.
Right, surfactant. And the second job?
The second job, which is key to this question, is that type 2 pneumocytes act as the progenitor cells, or stem cells, for the alveoli.
Meaning they can repair damage.
Exactly. When the alveolar lining, mostly those type I cells, gets injured, like in ARDS, the type 2 pneumocytes can do two things. They can proliferate, meaning they divide and make more of themselves, and then they can differentiate, they transform into type I pneumocytes to replace the ones that were damaged and restore the gas exchange surface.
So the type 2 cells are the repair crew for the alveolar lining. That's crucial.
Absolutely crucial for lung healing. The source apparently helped identify the cells in the diagram provided. B was likely red blood cells in the capillary. A, the capillary lining itself, endothelium. C was the flat cell covering the surface, the type I pneumocyte, right next to the capillary. D was the larger cuboidal granular-looking cell, that's the type 2 pneumocyte. And E was probably an alveolar macrophage, sometimes called a dust cell, with projections, busy cleaning things up.
Okay, so the takeaway is type 2 pneumocytes are the regenerative stars of the alveoli.
That's the main point for regeneration, yes. The source also gives a nod to the macrophages, mentioning they clear debris, but also produce proteases, enzymes that break down proteins, which becomes relevant in diseases like emphysema, where there's an imbalance between those proteases and antiproteases.
Got it. So even at that tiny microscopic level, knowing the specific jobs of different cells, gas exchange, surfactant production, regeneration, cleanup, is fundamental to understanding how the lungs work, how they get sick, and how they try to heal themselves.
It really is. It all connects. So we've covered quite a bit today, haven't we? We've gone through a whole range of cases.
Yeah, from a rare childhood tumor spotted by microscopy to sickle cell causing gallstones, a biostats question that was simpler than it looked.
Figuring out why sarcoidosis causes high calcium, seeing how diabetes makes yeast infections more likely, localizing a spinal cord injury from that mix of UMN and LMN signs.
Spotting a genetic cholesterol disorder from family history in St. Thomas, diagnosing a life-threatening aortic dissection partly based on the patient's height and a murmur, and finally, understanding which lung cell handles repairs.
And what's